Good morning and a warm welcome to all the dignitaries present here. I'm Shreyushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event, jointly hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation. And the focus of today's session is the Comprehensive Echocardiographic Examination TTE. So now, without any much delay, I would like to play a short welcome video.
Good morning and welcome to the Sunday breakfast session, which deals with TEE, that is transesophageal echocardiography and critical care echocardiography. And this is being conducted under the auspices of Indian Association of Cardiothoracic Surgeons, Indian College of Anaesthesiology, International Society for Cardiac Ultrasound, Global Heart Care Foundation, and Global University of Cardiac Sciences. Thank you for joining us. And today we'll be having a talk on comprehensive transthoracic examination, followed by discussion. Kindly post your questions and comments on the chat box. We'll try to address all of the questions and as far as possible. And with that, I would like to request Dr. Sanjivini Inamdar to take over. Dr. Sanjivini Inamdar is a leading cardiac anesthesiologist from Pune. She is extensively experienced in echocardiography and she is adept in both transthoracic as well as transesophageal echocardiography. We are lucky to have her with her today. And we have a speaker, Dr. Sridhara from our own center. Narayan Udyalaya. He is a leading intensivist with a great interest in echocardiography, and we are going to have a good session today. With that, I request Dr. Sanjivini Inamdar to take over and do the session.
Yes, thank you, Dr. Muralidhar, for this wonderful opportunity to moderate the intelligent faculty from medicine side, Dr. Shiva Kumar, who is MD and DM in critical care. So I think the students are very lucky today, and including we also, to have teaching from him and tips and tricks of the beautiful art of transthoracic echocardiography, which has almost replaced stethoscope today. Shivakumar is a consultant in critical care, and this is so important that we can save many lives with this knowledge. So I request Shivakumar to go and have his lecture. Shivakumar, please.
Thank you, ma'am. Thank you for the opportunity. I'll just share my screen. So can you see my slides?
Yes, sir.
Yeah,
Yes.
yeah. So
Presenter.
yeah. So very good morning to everybody. So in today's breakfast for tea session, we will be discussing about comprehensive critical care echocardiography. I have no disclosures in my talk. So, in my talk, I'll be covering the following topics. So, critical care echocardiography is quite extensive. So, it's very difficult to cover everything in half an hour, 45 minutes. So, I'll just give an overview of what a transthoracic basic echocardiography. I'll start with the basic echo views, some measurements like cardiac output measurement using echocardiography, assessment of LV function, what is used in the ICU. Most importantly, we use echo to assess fluid responsiveness in the ICU, and echocardiography to diagnose diseases in the ICU, cardiac diseases or other complicated issues in the ICU. So echo is a very important tool in the ICU. Nowadays, all of the ICUs have a transthoracic echo in hand, and most of the intensivists are well versed with a basic and advanced echocardiography as well. So echo gives information of a direct visualization of the heart. So you with the echo probe, you can look at the heart quickly. You can also look at the pleural cavity if there's any problem with the lungs as well when a patient is in respiratory failure, and also you can look at the great vessels with IOTA and IVC and make conclusions based on that. So echo useful in the ICU to assess a preload in your patient, especially in the ICU. What you want to know what the preload is. So how your ventricular function is, whether your LV function is good, bad, or is it moderate. So you want to know what the afterload is. So if you can come to know how your valves are functioning, if there's any valve dysfunction that is contributing to the problem in the ICU, and if there's any other problems like any pericardial collections or pericardial diseases that can be picked up using transthoracic echocardiography. Most importantly, like if you compare transthoracic versus transesophageal, transthoracic is can be done very quickly, and in a patient with in an emergency basis. So patient is in hypotension, in shock, so you need answer quickly. It is another important use of transthoracic. It is non-invasive. So unlike a transesophageal echocardiography, you may have to put the probe, but here it is non-invasive, easy, and the learning curve. Most of the with some training compared to a transesophageal ecography, you will start to do basic views, and then slowly, as within few months, once you're well versed with echo, we can troubleshoot most of the problems in the ICU. That is why echocardiography, transthoracic echocardiography becomes very important in the ICU setting. Most important uses in the ICU for transthoracic echocardiography is shock. So, shock or hypotension is one of the most common problems faced in the adult intensive care unit, where in the medical ICU, be it cardiac ICU, patient may be in shock hypotension due to various reasons. So, patient may be hypovolemic in a setting of trauma or some other hemorrhagic shock. So, patient may have cardiogenic shock, like patient may have LV dysfunction or MI admitted to the ICU. So, obstructive shock, like a patient coming with a pulmonary embolism, pneumothorax. So, patient may be hypotensive. So, with your transthoracic echocardiography, if most important use of echo would be to identify the type of shock and address treatment accordingly. Next important use is assessment of fluid responsiveness. Like in an adult ICU, so patient most will come with the shock. So you would have given some fluids, and any point of time if there is hypotension, the intensivist wants to know whether the patient can receive some amount of fluid, what is called as fluid responsiveness. If by giving fluids, the patients will the cardiac output of the patient improve, or so should I give more fluid? That decision will be based on your critical care echocardiography, which I'll cover in the next few slides. Trauma setting, echo is very useful to rule out causes of shock, as I mentioned, pneumothorax, pericardial tamponade, if there is any myocardial contusion, if there is blood, if there is hemothorax, if there is fluid collection in the abdomen. So trauma setting, in a quick assessment, in a rapid assessment, you can find out what is the cause of hypotension in the patient. In the ICU, other important reason is weaning difficulty. Suppose patient is in the ICU for many days on the ventilator, we are not able to wean the patient. Then we use ultrasound to assess problems with the patient. Like we do echo, we do look for any LV dysfunction, any diastolic dysfunction. We look lungs, is there any consolidation, any pulmonary edema that is hampering the patient from coming out from the ventilator, or if there is any other cause like a pleural effusion. And we look at the diaphragm as well to the diaphragm, if there's looking for any diaphragmatic dysfunction because of prolonged ICU stay can cause critical illness, weakness. So weaning difficulty also, echocardiography, ultrasound is useful. And coming to measurements, one of the most important measurements or common measurements we do is measurement of cardiac output. There are various other measurements that may be useful in a perioperative setup or in the theater, like a transesophageal echocardiography. But in the adult ICU, the other measurements may not be useful in a medical ICU patient. But most importantly, most important measurement would be you can measure the cardiac output and interpret how your patient, what's the cardiac output, and make your treatment accordingly. So first most is you will have to, whenever you start, you want to do a transthoracic echo, you will have to position your patient comfortably. So suppose in the ICU, unlike a patient in the cardiology OPD, your ICU patient is intubated, is obese, you may have difficult echo windows. So your patient may have COPD, you have a very poor window, and turning the patient may be difficult. So if always you can start with views. If you're not able to get to good window, you can always slightly tilt the patient to 30 to 40 degree lateral and then try to get a good window. So always make sure you stand comfortably by the patient. Your echo machine should be in line in vision to the machine. It's not that you stand on the other side. Make yourself comfortable so that you have hands on. It's comfort. The hands are closer to your machine, and then your vision is clear before you start off interpreting the echo. So I'll start with basic views. So that basic transthoracic views that is done and useful. So you have three windows: the parasternal window, the apical window, and the subcostal window. So I think most of them who are doing echoes, it will be they will be knowing the views. Just to it will be a revision for them. The parasternal window we have in the second, the third intercostal space. So you have two views: the long parasternal long axis view and the parasternal short axis view. In the apical window, in the apex, in the fifth intercostal space, in the mid axillary mid clavicular line, you have two views: apical four-chamber view and the apical two-chamber view. Subcostal window may be useful in a patient with many like post cardiac surgery when the window is poor, or a patient having emphysema when there is a poor window. You can use a subcostal window. You can look at the heart. You can look at the cardiac function. IVC can be assessed using the subcostal window. So three windows, and these are the views which I'll go in detail. So whenever you start using transthoracic echography, you can start with the parasternal long axis window. So patient will be supine. You'll have a pointer in your echo probe always. The pointer it should be on towards the patient's right shoulder in the second intercostal space. So your probe is here, and then you will have you will have this image. So you can see the left ventricle is a long axis. You can identify the structures in the parasternal long axis view. The left ventricle over here, the left atrium. So you can see the aortic valve, and here the right ventricle. So parasternal long axis view is useful to make some measurements as well. If you want to, in the parasternal long axis view, you can use it in M mode. So this is the parasternal long axis view. Again, identify the structures: the left ventricle, the left atrium, the aorta, and the right ventricle. So you will have the in M mode, you can use measurement. Parasternal long axis view you can also use to assess the LV function, to make some measurements, and also to assess for any pericardial effusion that may be there in the parasternal long axis view. So after you're finished with the parasternal short long axis view, next you will move on to the parasternal short axis view. So same in the left or second, third intercostal space, your pointer, once it is in the right, direct towards the right intercostal, towards the right shoulder, slightly rotate the probe 90 degree towards the right. You will see the parasternal short axis view. In the short axis view, you will see the left ventricle like a circle, so you're cutting the left ventricle. So you will see the left ventricle like a circle. You'll see the contractility of the left ventricle. Short axis is useful in the ICU to mainly to assess the LV function, how the LV is functioning, to look for any regional wall motion abnormality. Is there any RWMA that is there? You can you look for pericardial effusions. So that can, if the patient having MI, if you want to look for any specific wall that is having hypokinesia, that can be assessed using parasternal short axis view. In the parasternal short axis view, there is various levels. So first thing is at the level of the aortic level. So at the aortic level, you will see the aortic, the root can be seen. You can see that aortic valve is that is what we call the Mercedes-Benz sign. This is the aortic valve. So at the mitral level, we'll see the mitral valve opening and closing. This is what we call the fish mouth sign. So we can see that the mitral valve is opening and closing is at the level of the, is little lower down, you'll see at the mitral level. So as you tilt the probe up and down, you will see the personal short axis view at various levels. On the left, you will see the aortic level. You can appreciate the aortic valve. On your right, you can see that at the mitral level, you can see the mitral valve opening and closing. If you still further tilt the probe down, you will see the short axis view at the level of the mid ventricle level. So at the level of the mid ventricle level, you can identify the mainly used to assess the LV function. If there is any clots that you want to assess, if there is any abnormal, if you mainly to look for any pericardial collections, or you can also to assess the LV function. So if you still tilt the probe way down at the level of the apex. So as apical level, mainly useful in a patient with any apical hypokinesia or a patient having a cardiac disease where you want to specifically look at apical contractility. Slightly, if you rock the probe down, you will identify the apical hypokinesia or apical contractility. So these are the various levels of the parasternal short axis view where with a transthoracic echo, you can identify the problems. So once you finish the short axis view, long axis view, parasternal view, then you will come to the most important view, the apical four-chamber view. So apical four-chamber view, you keep the probe in the mid clavicular line at the apex in the fifth intercostal space. Pointer is here towards the patient's left, and then you see the four chambers. So you see all the four chambers must be neatly seen. You can see identify the chambers, the right atrium, right ventricle, the left atrium, and the left ventricle. So you can appreciate the contractility of all the ventricles. If there is any valvular pathology can be identified. If there's any pericardial collection also can be identified in this window. So you can always identify the LV function as well. And if there's any valvular pathology like regurgitation or if there is stenosis can be identified using apical four-chamber view. Gives an overall picture of the contractility can be done. So once you finish the apical four-chamber view, there's a apical two-chamber view as well. So if you want to see the LV left ventricle in more in detail in the apical four-chamber view, which is slightly tilt the probe towards cephalad, use 60 degree, use 60 to 50, 60 degree, you will see the apical two-chamber view. So on your right, you will see the apical two-chamber view. You will see appreciate the only you're seeing only the left atrium, the left ventricle. To mainly to look at the contract, you can appreciate the contractility of the left ventricle. You can appreciate any valvular pathology of the mitral valve, and if you want to measure, if there's any, if you want to take a reading of the Doppler measurements across the mitral valve, can be done in the apical two-chamber view. So in the ICU, the basic views that you can start with the personal long axis view, short axis view, and then you can move to the apical four-chamber view, and then you can move to the apical two-chamber view. So then you can move to subcostal view. So what happens in a patient who is very obese is useful in a patient who is having emphysema like a COPD, where you don't have a window, and especially in a patient with trauma patient who have a pneumothorax, subcutaneous emphysema, or a post-operative patient who has immediately who's come from the theater after cardiac surgery, where there may be some subcutaneous emphysema where the window is very poor. Then you can use a subcostal window. So subcostal window, your pointer to be cephalad in the just below the xiphoosome, you rock the probe and tilt the probe cephalad, you will see the subcostal window. So the window is through the liver. You will see the acoustic window through the liver. You identify the four chambers, right atrium, right ventricle. You have the left atrium, left ventricle. So you can identify the contractility. You can identify if there's any pericardial collection or if there's any tamponade that can be looked at, and you can identify the valves as well. So the subcostal window is basically in an emergency setting where you're not getting a good views. So it is difficult to make if cardiac calculations in subcostal window, but to fairly to assess the LV function, rule out pathologies, it can be useful. So other important use of subcostal window is IVC assessment. So in the subcostal window, so you can see that this is the acoustic window of the liver. So you can see that the IVC. So IVC can be seen, and then you can measure the IVC. So hepatic vein confluence will be there. That is over here. So slightly about a 0.5 centimeter proximal to that, you can use a M mode and then identify the IVC diameter. If you want to make IVC, if you want to measure the IVC diameter, subcostal window can be used. So we finish the basic views. So then we will move on to other important estimation, ejection fraction estimation. So in the ICU, most of the times we want to know how the heart is functioning. Like if you, whether a patient has severe LV dysfunction, the patient has a mild LV dysfunction, or patient is having a normal LV function. So we don't want to know the exact number in an emergency situation. We can estimate it for purposes, but in a patient is having hypotension shock, you want to know whether can I give fluids? How is the LV functioning? So visual estimation is what we commonly do in the ICU. That has been like visually eyeballing method. You look at the LV function. LV function is good. Is it severe LV dysfunction or moderate LV dysfunction? Ejection fraction is nothing but the ratio of stroke volume by end diastolic volume into 100. So various methods can be used to measure the ejection fraction in the ICU. Like you can use the fractional shortening mode, M mode can be used, the fractional area change can be used, or the Simpson's biplane method can be used if you want to compute the ejection fraction in an exact, but visual estimation is what is commonly done. So you can see a visual estimation eyeballing method on your screen over here. You can see in the short axis view, personal short axis view, you can see that the LV, all the ventricular walls are moving well. So it's coming in. So this patient has a normal LV function. Similarly, on your right hand side screen, you can see that the LV, you can the LV, there is some regional wall motion abnormality as well, and there is LV dysfunction. LV is not contracting well. So the patient is having severe LV dysfunction. Visual estimation, we don't visually, if you want to tell, if you want to compute the ejection fraction, maybe 15 to 20%, but for the ICU point of view, if you know that the patient is having a severe LV dysfunction, this may be a contributing factor for hypotension. So later, if you want to estimate the ejection fraction, you can do the calculations as I'll explain in the next few slides. So fractional M shortening or M mode can be used to estimate the ejection. So in the parallel long axis view, you can use the M mode. So you'll get a good parallel long axis view. Use the M mode. So you will identify the end diastolic diameter and the end systolic stand. So you can see that the maximum diameter will be the end diastolic diameter, and the minimum diameter will be the end diastolic diameter and end systolic diameter. So the fractional shortening percentage is given by left ventricular end diastolic diameter by left ventricular end systolic diameter divided by left ventricular end diastolic diameter into 100. So from the fractional shortening, you can compute the ejection fraction. Most of the modern day machines will give you the ejection fraction once you put it automatically with the M mode. So other methods to estimate the ejection fraction is fractional area change. So in your parallel short axis view, you can freeze the image in a, so this is an end diastole. You can see that the left ventricle, this is an end diastole, and you can freeze the image in end systole. So end diastolic area, end systolic area, you can compute, you can trace the endocardial border, and then you can compute the area. So then you can estimate the fractional area change. From the fractional area change, you can compute the ejection fraction, the machine using calculations. So Simpson's method and fractional area change can be used to compute ejection fraction. Other methods that can be used is Simpson's biplane method. So in the biplane method, in the apical 4-chamber view or a 2-chamber view, so we freeze the image in end diastole and end systole, and then we trace the endocardial border. So in the machine using Simpson's method, so the ejection fraction is given by the formula by left ventricular end diastolic volume by left ventricular end systolic volume divided by left ventricular end diastolic volume into 100. So once we trace the endocardial margin in the end diastole and end systole, then we can, in the machine will we can calculate the ejection fraction using Simpson's biplane method. So once I've covered ejection fraction estimation in the ICU setting, the most importantly, it will be the visual estimation. You visually will estimate how the LV is functioning. So other important measurements in the ICU will be measurement of cardiac output. So before we estimate the cardiac output, we need to know the estimation of velocity time integral. So what is velocity time integral? So uh, velocity time integral is nothing but is a summation of, suppose we have a area where the blood is flowing, and with Doppler we calculate the blood flow velocity. Velocity time integral is the summation of at that point of time, what is the sum of all the flow of all the RBCs that are flowing in that area. The summation of instantaneous flow rates is velocity time integral, that is given in centimeter. So is nothing but the distance that blood is traveling in that area when we use Doppler to measure the velocity. We use pulse wave Doppler to measure velocity time integral. So suppose we want to measure velocity time integral in the left LVOT or any iotic area, wherever, whichever region we want to measure. So we use pulse wave Doppler, and we get a graph like this. And when we trace the graph, the machine will give us the velocity time integral. Velocity time integral is in centimeter, is the distance the blood travel at that point of time using pulse wave Doppler. So, or the stroke distance, VTI in centimeter, or the stroke distance. From the VTI, we can compute cardiac output. So this how to calculate VTI. So this is in an apical 5-chamber view. So once in a 4-chamber view, if you tilt the probe cephalad, you will see the 5-chamber view. So you have the left ventricle here, you have the LV OT over here. So you'll put the pulse wave Doppler in the LVOT, and then we press pulse wave Doppler. You will see a waveform like this. So then with the waveform, you will trace some machines will have auto VTI. So once we get the trace, if you put VTI machine, but most of the times you will have to trace the margin. Once you trace the margin, you will get a VTI. So your aortic valve VTI is about you'll get some value. So from that, you can calculate the cardiac output. So from the VTI, you can calculate the stroke volume. So stroke volume is nothing but the area, the cross-sectional area in the region where we measure VTI into velocity time integral in centimeter. Suppose we measured VTI in the region of the aortic valve. So you'll have to find out the diameter of this area. That will from and put it, you'll get a cross-section area multiplies by the VTI in that area will give you the stroke volume. So from stroke volume into heart rate will give you the cardiac output. This is how you can calculate VTI from using echo from stroke volume measurement. So what are the uses of VTA in the ICU? So one is to estimate the cardiac output. If once you calculate the cardiac output, you know what the cardiac output is, and you don't need an invasive catheter. Serially, you can make the measurement, calculate the VTI. You can, if the patient is having cardiogenic shock, you can titrate therapy. Maybe start the patient on dobutamine and just see how the VTI is doing, improving or not. Then you can calculate the cardiac output serially, and then just see how the patient is doing from yesterday to today. That is one use of VTI in the ICU. Other important use of VTI is assessment of fluid responsiveness. So fluid responsive is nothing but in a patient with hypotension in the ICU, will the patient's cardiac output improve by giving fluids? Like suppose I give fluids to my patient, will the patient's hypotension, will the cardiac output improve? Will the perfusion improve? So to give an example over here, so we have a patient where VTI was 10 centimeter before I gave fluids to the patient. Okay. After, so we gave a fluid bolus of about 250 ml, measured the VTI. Yeah, after 1 or 2 minutes, then VTI increased from 10 centimeter to 20 centimeter. So the cutoff is the VTI should change by more than 15%. If the change of VTI is more than 15%, that means the patient is having fluid responsiveness, or patient, you can consider giving fluids to this patient if the patient is in shock. So that is important. Other important use of cardiac output assessment or VTI in the ICU. So here you can see that there is a 50% change from 10 centimeters increase to 20 centimeter. So there's a 50% increase. So the patient is having fluid responsiveness. So other use of VTI is in the ICU. What we do sometimes, when we don't want to give fluids. So with patients having a cardiac dysfunction, we don't want to give fluids. So we do a passive leg raise. PLR is passive leg raise test. Suppose we have a patient with septic shock in the ICU. Patient is intubated on the ventilator. A patient is in shock. So whether patient is having some LV dysfunction, some pulmonary edema, we don't want to give more fluids. So we want to know whether we want to give some fluids. We want to know whether the patient is fluid responsive or not. So if the patient is on the bed, so you do a passive leg raise test with VTI. So ideally, you need a cardiac output monitor, invasive cardiac output monitor, and you look for a change of cardiac output after the maneuver. But if you have a echo with VTI, that can be used at the bedside. So this is how it has to be done. So your head and side should be elevated to about 45 degree when you start the passive leg raise test. So you will take a reading of VTI. So you will measure a VTI, suppose VTI is around some reading you'll get, then immediately what you do, the full bed. It's not that point to note, it's not that you do just head down. The whole bed, you have to turn it up. So 45 degrees, this whole bed comes down. Just wait for about 1 or 2 minutes till the BP, wait 1 or 2 minutes, then you measure the VTI again. So here there is a component of water transfusion. There's no risk of giving fluids. So once you measure the VTI, if the VTI increases more than 15%, then the patient may be fluid responsive. So VTI with PLR is a handy tool in an ICU patient where we want to assess for fluid responsiveness, especially in a septic shock patient where we want to give fluids. So these are the two uses of VTI. Other important uses of critical care echography is assessment of valves. So in this patient, you can see that there is some RARV dilatation. Patients having pulmonary hypertension. Here you can see that there is, you use color Doppler, you can see that the blue jet on the right hand side in the right atrium. So so you'll have patient, maybe there could be some regurgitation. So on your left hand side you can see that again the valvular regurgitation can be picked up using echocardiography in a cardiac. If patient having if patient coming with some cardiac disease to a medical ICU, so valvular pathologies can be picked up. So other use of echocardiography is looking for any other like here you can see that the parasternal long axis view. You can see that there is abnormalities that attach to the valve in mitral valve. It looks like it may be a vegetation. You may have to do a transthoracic, transesophageal echo to evaluate further. But with transthoracic echocardiography, you can assess the valves for any pathologies that can be identified. So other important use of transthoracic echo is IVC. So IVC is used to assess fluid status. It is used to assess congestion and treat in a patient heart failure, in a patient with septic shock. IVC is an important aspect of a transthoracic echo. So this window is in a subcostal view. You can see that this is the confluence of the hepatic vein and the IVC. So just before a confluence of the hepatic and IVC, just about 0.5 centimeters where you measure the IVC diameter. So you can use M mode over here and measure the maximum diameter and the minimum diameter. So you can use M mode over here. You can see that this is the hepatic vein, this is the liver, the subcostal view, the confluence of the IVC and hepatic vein. Just proximal to that, you can use M mode and IVC. You can get the maximum diameter and minimum diameter. And from the diameters, we have the formulas to to evaluate for fluid responsiveness. So IVC distance ability index is for patients on invasive ventilation. So patient is sedated, is on invasive ventilation. You can use this formula is IVC maximum diameter minus minimum diameter by IVC minimum diameter. It will give you IVC distance ability index. And if it is more than 18%, then the patient may be fluid responsiveness. So you can consider giving fluids when your other echo indices are also indicative of fluid responsiveness. So collapse rate index is in a patient who is spontaneously breathing. Patient is having spontaneous respiration. IVC maximum diameter minus minimum diameter by IVC maximum diameter will give you collapse rate index. If it's more than 50%, patient may be fluid responsive. So distance rate index is in a patient with who's on positive pressure ventilation, collapsibility whose patient is on spontaneously breathing. There's other indices are delta IVC, that is maximum diameter by minimum IVC by IVC mean into 100 will give you delta IVC. If it is more than 12%, that means your patient may be fluid. So you can do either one of the indices and impute whether the patient is having fluid responsiveness or not. So just to give an overview of various causes of shock and how a transthoracic echo can be used. So this is the patient with hypovolemic shock in a trauma setting where there is a patient has lost a lot of blood, patient is hypovolemic. You can see that in a short axis view, the patient is hypovolemic. The LV is really LV is small and hyperkinetic. We call this as a LV kissing sign. So both the ventricles are kissing each other. So it's a LV is emptying. Short axis only you can make out that LV patient has a good LV function. There is no pericardial collections. So patient having evidence of hypovolemia. If this is an subcostal window, you can make out that LV function is good. LV is kissing each other. The LV is hypovolemic. LV is small, hyperkinetic. So there is evidence of hypovolemia. So patient is having hypovolemia. And again, you come back and assess the IVC. The IVC is visibly collapsing. No need to measure the indices, but you can see that the IVC is visibly collapsing. So it is an evidence of hypovolemia. So patient is in hypovolemic shock. So in cardiogenic shock, what are the echo parameters? So using transthoracic echo. So you can see that in a short axis view, there is severe LV dysfunction. The LV is hardly contracting. There is some regional volume motion abnormalities. A parallel long axis window as well. There is severe LV dysfunction. There is some pericardial effusion, but there is no tamponade that I can see. There is not much RRA dilatation. When I see the IVC of this patient, IVC is visibly distended, is more than 2.5 centimeter. So there is an obvious component of cardiogenic shock. So in this patient, the cause of shock is cardiogenic shock. So using echo, you can make out and diagnose cardiogenic shock and treat accordingly your patient. So what happens in obstructive shock? So you can see that obstructive shock scenario is a patient with pulmonary embolism. You can see that the patient is having RRV right. There is visibly severe dilatation of right atrium, right ventricle. So you can see the left atrium, left ventricle, the LV interventricular septum is pushed towards the LV. You can see that our right atrium, right ventricle is visibly dilated. Similarly, in a partial short axis view, if you can see that the right ventricle is visibly dilated and pushing the left ventricle, the septum is being pushed, left ventricle septum is being pushed. So patient is having what we call a D-shaped ventricle sign. D-shaped ventricle sign, left ventricle, the right ventricle is severely dilated. So indicating of a right ventricular dysfunction. It may be a pulmonary embolism. You may have to evaluate further and further assessment of RV dysfunction. And we measure the RV function using TAPSE, RV systolic function using TAPSE. You can use M mode and keep it at the junction of the tricuspid valve and the annulus. And annulus, you use M mode, you'll see the TAPSE. So TAPSE, normal TAPSE, if it is less than 16 millimeter, the patient is having RV dysfunction. So RV systolic function is impaired. So this patient may be having a pulmonary embolism, which will require further intervention in the form of further evaluation in the form of CT pulmonary angiogram or intervention in the form of thrombolysis can be done. So here, cardiogenic patient, what is happening? Here there is in a long axis view, you can see that a small posterior collection pericardial effusions there. Here in another patient in a subcostal view, you can see that there is a severe pericardial, significant pericardial collection, and you can see that the RV is collapsing in diastole. So this patient is in pericardial tamponade. So plaques view can be used for small posterior collections. So if you look at here, it was small collections, but you can use the subcostal, the apical four chamber view to evaluate for tamponade. So in the subcostal view, you can you can measure you can from the size of the pericardial collection from the free wall to the pericardium, and the subcostal view can be used to put a drain. If you want to drain the collections using a guided needle, you can use the subcostal window to drain collections as well. So I've covered the adult comprehensive echo in the ICU is quite extensive. It is difficult to cover all aspects. I've just gave an overview of the basic views of critical echocardiography in the ICU, how we use echo at the bedside to measure fluid responsiveness. So how to measure VTI. So velocity time integral in apical five-chamber view using pulse wave Doppler, you will measure the VTI. VTI can be used to assess fluid responsiveness. VTI variability can be used, and after giving fluids, you can check the change in VTA, or you can do a VTA change with passive leg raise text. You can use IVC assessment to assess fluid responsiveness in the ICU. Most important use of echo in the ICU is evaluation of cause of shock. Made septic shock, cardiogenic shock, obstructive shock, type of shock. Categorization can be easily done using transthoracic echocardiography in the ICU. So echo can be used to evaluate for pericardial collections, and critical care transthoracic echocardiography is most important advantage is a rapid tool. It will give you the answer quickly, and it is non-invasive compared to other methods like visual echocardiography tool. So the learning curve is steep. Once you need some practice, but it is much easier than the transvisual learning curve. So slowly with practice, intensivists can be well versed with the assessment of these patients in the ICU, and any patient with uh, in shock can be assessed in the ICU, and therapy can be like patients having cardiogenic shock. You can start therapy accordingly. Like you can start like patient will require treatment for myocardial infarction, antiplatelets, or intervention, or mechanical support. And if the patient is having septic shock, maybe you source control, you control appropriate antibiotics, drainage of area where there is any pus that needs to be drained. And obstructive, if identify the cause of shock is obstructive, then you may have to treat the patient accordingly, like maybe thrombolysis or further evaluation for the obstructive cause, like pneumothorax. You have to, and other important use in trauma. Immediately, the echo can be used to identify there's any pericardial collections or tamponade, and therapy can be titrated accordingly in such situations. So, thank you.
Thank you, Shiva Kumar. It was wonderful, wonderful. Our students, they have been briefed of the risky scenario in a short while, and echo presentation is all videos, images and images, and you have beautifully shown all the ideal images. Really, I'm thanking you for that presentation. There are a couple of questions, but before that, I would like to ask you, in your LVOT VTI slide, you have shown VTI of 37. Can you go
Yes.
back to that slide, please?
I'll just go back to slide one.
Yes. LVOT VTI. Yes, yes, this one. So, yes, 37. So, I
Yes,
just
quite high.
wanted to ask you if you remember this patient, was he a healthy young adult having that much of LVOT VTI?
No,
Usually we see 20,
20,
22,
20, yes, ma'am. Yeah,
25.
yeah. Yeah, I
So,
don't
can
remember
you
that patient.
explain
No,
this?
just, yeah. I
Excuse
think
me,
VTA is little higher side.
excuse
So,
me. This is not LVOTV, this is aortic valve.
aortic valve VTA.
So one should be little away from the valve. Though the closing click is seen, that is okay. But I think you should have avoided the turbulence. You should have gone into a quiet blue thing, which is very important, because if you get 37 in the beginning, suppose this guy is sick, and if you find 37 before and next day if he shows say 18, you would say he's deteriorated too much, which may not be the case actually. Another important thing, it is just another thing, that if you see LVOT VTI one big, one small, one big, one small, alternating,
Yeah.
can you draw some conclusion just looking at
By
that?
looking at a patient, evidence of hypovolemia may be there, looking at similar to a pressure variation. So if your LVOT VTI is changing rapidly with every respiration, so beat to beat variation, if the patient does not have any arrhythmia, the patient is having a normal sinus rhythm. So evidence of hypovolemia may be there. You can measure the VTI as well. If you,
So
so
VTI, suppose one is 20, and
okay,
next VTI is 10, 20, 10, 20,
10.
10.
Hypovolemia is one thing that will be in my mind. So I will.
One more important thing, it
It
is
will
called
be
as,
pulses alternance.
correct, correct. This is Doppler alternance.
Doppler
It's a
alternate.
sign of severe LV dysfunction. So just
I
looking
just
at,
want to know, Sanjivini, can this happen in ventricular bigeminy when there is every second beat is an ectopic? Can you get something like that, what you described?
in bigeminy, that whatever that ectopic bit is coming, it is a big bit. So it may not decrease. LVOT
The
VTI may not,
alternative bit will be small.
but the smaller bit will not be less than, 10 or something like that. It will be normal 20, and that another big bit will be little higher than that. And then there will be pause. There will be pause, which
Yes.
is seen in ECG. So this is very typically seen. I have seen this alternate Doppler alternance many times, and severe LV dysfunction does cause it. So this point should be little away from the. That is one
Okay.
important thing.
Okay.
Another important thing is, have you seen, since you are working in this scenario day in and day out, have you seen tricuspid valve trauma anytime?
TR, you've seen it's
Not
TR
TR, trauma, anything,
trauma.
tear, perforation, whatever, because the stab injury
Yeah.
happening
I think
so frequently today.
I've seen blunt myocardial contusions I've seen, ma'am, but I've not
Not
come across
tricuspid.
tricuspid.
Okay, okay. Okay, it was another. Mulinder, can we go to questions and then
Yeah,
come back to
before
the
that,
discussion?
I just want to make one comment. I'm Dr. Shiva Kumar. I'm really sorry. And announced your name as Sridhar. This is the second time I'm doing it. I'm sorry about it.
Okay,
That's
sir.
the first one. Second thing is, I just wanted to say that in a sort of lighter vein, when I was doing the echocardiography in the theater and the heart was empty, the papillary muscles were kissing each other. I announced that papillary muscles are kissing, and the surgeon said, "How romantic!" That's what he said. So, in one way, it's good that you know the reason for hypotension when the papillary muscles are kissing. With that, I open the discussion for the chat box. Please proceed, Dr. Sanjivini.
Yes, yes. There is one question. Please explain regional wall motion abnormality uh, related to different coronary territories. Can you just because your slides are
Yeah. Yeah.
videos are so beautiful. You can
I'll
go
just
back to video
I'll
and
just
explain.
go
Correct.
back to the videos, ma'am. Yeah. So if you want to look for any, this is the Parashon short axis view. So in a short axis view, if you want to look for any regional, so you have the right, it's a interventricular septum here. So you'll have the anterior wall here, posterior wall. So if you want to look for any specific territory that is not moving, then in the short axis view, you can, if the septum is hypokinetic, you can identify the dyskinetic septum. So if there's any hypokinesia or specific wall that is not moving, you can identify the regional wall motion abnormality. But if you tilt the in a short axis view, as I mentioned, in the apical, if you want to look at the apex, you can rock the probe apic and tilt the probe a little downwards and look for any apical hypokinesia. So anything else you
So
want to
I
add, ma'am?
think the person wants to know the coronary distribution. I don't know whether he wants to
I
ask
don't
that.
know.
Anyway, here I would like to keep the same slide.
Yeah.
Just show the IVC flow. Just if it can. So this is the beautiful traffic signal sign. Traffic signal. Traffic is congested in IVC. This is the blood which is thick because IVC everything is blood is coming back due to poor right ventricle. So this is a beautiful sign, that is traffic signal sign. So this just wanted to add this
Okay.
comment. So
I
coming
think
to
there will
another.
be a bigger discussion on the left ventricular function assessment. So that time we'll be covering regional wall motion abnormalities. Actually, when you look at regional wall motion abnormalities, the LV is divided into 17 segments, and you have to look at all the segments at basal level, mid level, and apical level. Basal level 6 segments, mid level 6 segments, apical level 4 segments, and the apex itself is 1 segment. So totally you have 17 segments. I think we'll be dealing with this in the forthcoming classes. But in brief, you score the wall motion depending upon how well it is thickening and how well it is reaching the midline. I mean to say reaching the endocardial motion going towards the center, and it is classified into hypokinesia, akinesia, dyskinesia, and paradoxical motion. I think we'll be dealing in a little more detail later, so we can go on to the next.
Yes. Dr. Manjula wants to know, how to see right ventricular clot? Which view? She is
Yeah.
one of the faculties, and it's a question from a faculty.
You can apical four chamber view. You can identify if there's any right RV clot is there. If you want it, apical parasol long axis, it may be difficult, but in a apical four chamber view in a transthoracic window, you should be able to identify if there's any RV clot.
This is the apical four chamber focused RV view. That is the better way to, because many times when we see apical four chamber, RV is not seen well. So you have to just go up and towards the right to see where LV, you ignore LV. You may not see LV fully, that is okay. But RV should be seen beautifully. And this is RV focused view in apical four chamber view. Another question is by Chetana. Can you explain diaphragmatic function for assessing readiness of
Um,
extubation?
So diaphragm I have not included in the we don't have the slide, ma'am. So because it was comprehensive echo, so we mainly look at using ultrasound to look at the thickness. So we assess for the thickness in the and thickness, and what we saw we call one is thickness, another thing is excursion. We see how the diaphragm is moving with every inspiration or expiration. So the patient is on the ventilator. If the patient is having spontaneous efforts, so with the echo probe itself, in the right side, when there's a liver window, we just look at the diaphragm. We measure the thickness in the other probe, the vascular probe, high frequency probe. Then in the echo probe, we measure the excursions. Excursion, if it is more than 1.5 to 2 centimeter, that means the diaphragm is moving well. If it is less than 1.5 to 2 centimeter, that means the diaphragm is hardly moving with every respiration. And if the thickness is reduced, if the thickness, normal thickness should be at least, we see 0.5 to 0.8, 1 centimeter. If it's less than that, patients having thickness is reduced, risk of the patient having critical illness weakness. So two things that we see, the diaphragmatic excursion and the thickness that we see. So I don't have a slide to show.
This we can learn again in lung scan.
Lung ultrasound,
Yeah,
yeah.
there'll be a separate
Yes.
session on lung
Yes.
scan and
Yes,
diaphragmatic
yes. So
assessment.
Nimisha is asking, can you please explain TAPSE
Yeah, I'll go to
in
that slide.
pulmonary embolism?
Yeah.
TAPSE in pulmonary embolism.
In a patient with pulmonary embolism, mainly you want to assess the RV systolic function. TRAPSE is a tricuspid annular, the tricuspid annulus. So in a vertical axis, how your tricuspid annulus is moving. That is what you want to know, and indirectly you're assessing the RV systolic function. So you can use the apical four-chamber view. So yeah, first identify the tricuspid annulus where it is clearly. Then you use M mode. And with M mode cursor, you place it on the tricuspid annulus and press M mode. Once you press M mode, you'll see this image. So you'll see this waveform kind of thing. So you will take the measurement of the tricuspid annulus from the peak to the trough. It's not that you take all the annulus from the peak to the trough. You take the reading and you measure the tricuspid annulus systolic excursions. How the tricuspid annulus is moving in a So normally it should be more than 16 millimeter. If it is more than 16 millimeter, the RV systolic function is normal. If it is less than 16 millimeter, then the patient is having RV systolic dysfunction. So mainly the apical four chamber view, you use the M mode cursor on the tricuspid annulus and press M mode and measure from the peak to the trough, you take the reading. That is how you measure the TAPSE. Anything you want to add, ma'am?
No, only post-operative TAPSE is not a very good indicator, and it is indicating only longitudinal functions, doesn't tell you about other functions. And here, this is, I think, pulmonary embolism slide, isn't it?
Yeah, yes.
I just wanted to add that McConnell sign.
McConnell sign.
Here that apex is hyperdynamic, RV apex is hyperdynamic, but other walls are not moving at all. This is classical McConnell signs. Okay, going to another question. Dr. Sanjit, another faculty from this group, she wants to ask whether VTI is validated with other dynamic parameters of fluid responsiveness.
So for fluid responsiveness, the validation is before it was mainly with invasive cardiac output monitoring. Like before and after giving fluids, they look at change in cardiac output, invasive cardiac output. If it is more than 15%, then the patient was fluid. That is very much validated. But even with there are enough studies to state that change of VTI. Instead of measuring cardiac output, if you don't have a cardiac output, even VTI measurement is equally equivalent to a
Very sensitive.
yeah, it's very
Yes.
sensitive to.
VTI has been given tremendous importance, and that is why artificial intelligence has included VTI first in this scenario. So coming to another question, Sandeep Kumar, he wants to know, patient on mechanical ventilation, sedated, paralyzed, IVC collapsibility is reliable marker for respiratory variation. He has explained, you have explained it actually.
I'll go
But
back to
you
the
can,
slide.
It is not the collapsibility, it is the distensibility during ventilation.
Yeah, distance. That's right. That's right.
It is collapsibility is not seen at all in IP because
Here,
already
can I ask one question because I just want to clarify. When you're looking at distensibility in a patient on mechanical ventilation, do you have to have a tidal volume of minimum of 8 ml per kg or any tidal volume is okay?
For IVC, any title does not matter, so I don't think it should matter.
Right.
Yeah.
Please go to the
actually, actually I wanted to ask Shiv Kumar, are you doing this distensibility?
We don't measure the index, ma'am. We mainly look at
Because
the LV
we do
function.
it. We do it in
Do it
theater. We use it.
theaters, but
okay,
we don't calculate it by I look at the diameter. So
correct. Okay.
We do it in theater. Usually in routine cases, we look at the IVC and the distensibility. Thank you.
Dr. Abhay Prakash Rajole, he wants to know pointer direction in subcostal view.
I'll just show him, ma'am. No, I'll just show him.
That is important actually.
Yeah. So your pointer to be cephalad. If so, here is echo probe. The pointer is here. Pointer will be towards the patient's head. So in the subcostal view, the probe is just under the Xephus sternum. So you can see that pointer is here. Pointer is towards the
I think it is at the 3 o'clock, they say.
cephalad. Maybe you can keep it at
3 o'clock.
o'clock.
2 to 3 o'clock, depending on patient's anatomy. The more important thing over here is you have to insinuate the probe in the zipisternum area.
Yes.
If you don't insinuate, you will not see anything. That is very important. And you have to explain patient before that you are giving little pressure. Another Rohini wants to know where should the pointer be while measuring IVC diameter?
Same in a subcostal view. If your pointer will be the same in a subcostal view, but sometimes we use IVC across the liver window. Sometimes we don't get a subcostal window. We can use it across the liver in the mid axillary line as well. But here subcostal window, the pointer will be the same point in a position, but slightly you may tilt the probe downwards
Right.
when you notice
Towards the IVC side. This
towards IVC.
simple thing is that you have to face the footprint of the probe toward the surface anatomy of that organ. IVC is on the right side, so just make the footprint look towards IVC, so it's little anti-clockwise. You have to do that rotation movement anti-clockwise. Rati Prabha, what is the best view of IJV cannulation in VV ECMO? IJV internal jugular.
To look at the when we're cannulating, to look at, you can use the apical four chamber view. I mean, you mainly want to look at where the cannula is, whether it cannula. So you can use you can use this apical four chamber view. Look at the heart. Mainly to concentrate on the RARV, right? So uh, I didn't get the question whether she wants to the vascular axis. I understood it as to look at the cannula position. So maybe you can use the apical window, apical four chamber view in the cannulate.
Muralidhar, does she mean that you should use suprasternal views or something like that, where
Sorry,
you
what
see
is
all
that?
the neck
I
vessels?
didn't get it. What is it?
She's asking Dr. Rati Prabha, what is the best view for internal jugular vein cannulation in VV ECMO?
See, for internal cannulation, we use the ultrasound for vascular access. The probe is placed at the neck on the right side. You can use one of the three techniques. One is the short axis, long axis, or oblique axis. I think
In
echo
suprasternal views. In suprasternal. Where do
oblique
you
suprasternal view is not used for IJV. It is the ultrasound which is used. Echo is not used. Echocardiography is not used for IJV routinely.
Okay. Dr.
But
Roja
also,
Mathur.
no. If it is for positioning and looking at the guide wires, you have to go for the bicable view and look for the advancement of the guide wire through the SVC into the RA, and also look at the tip of the cannula near the in the IJV, which is entering through the SVC to the into the RA, usually keep it slightly above the RA and SVC junction, if that is what the question means.
IJV can be, SVC can be addressed from suprasternal view in transthoracic. If this is to be done with transthoracic, we can do suprasternal and just see beautiful SVC, and you can see that guide wire, I think. Okay. Again, Roja, can we see pericardial effusion only in subcostal view but not in four-chamber view?
Pericardial effusion can be, you can see in four-chamber view, but subcostal, if you can appreciate it in subcostal view as well, in the apical four-chamber view also. But subcostal, if you want to drain it, you can use it as a guide to drain.
If it is quite large, one can see it in four-chamber, but small pericardial effusion can be quickly seen in subcostal views because it is collected over the anterior part of our V easily. Dr. Rishi Nara wants to know how to differentiate between aorta and IVC in subcostal view. Good question. Very nice question.
So in the subcostal view, if you just rock the probe, you will identify. Sometimes will confuse the aorta as IVC. So one thing is, so you identify the hepatic vein, identify the confluence of the hepatic vein and the IVC. The hepatic vein draining into the big vasculature, that will be the IVC. So then slowly, if you rock the probe, tilt the probe toward laterally, you will see the aorta. So aorta is pulsatile, thick walled compared to the IVC, but you will identify the IVC drainage into the right RA. That will be the IVC compared to aorta will not drain into the right atrium.
Correct. And you can put pulse wave Doppler in
Pulse wave
aorta
Doppler
and
and then
yes, beautiful positive waves in aorta with velocity of around 50 centimeter to 100. Bharat Kumar wants to know which view to assess ASD and fossa ovalis. Good question.
to assess ASD.
ASD or fossa ovalis means he wants to know interatrial septum.
Apical four-chamber view, that is what, anything ma'am you can add, ma'am?
Subcostal for long four-chamber view. That is because your 2D is perpendicular to the septum, not in four-chamber. Four-chamber you may see drop, which is not a ASD, but it is a because the beams are parallel, you may not see in the middle portion anything, and you will think that it is ASD. And of course, it is a very low flow phenomenon, so you may not see color, also may not help you. So it is always subcostal. Subcostal bicaval view is also there to see interatrial septum beautifully. You just have to turn clockwise and see the bicaval view, like how we see bicaval in transesophageal, the same way we see it over here. Okay, that is a good question. Yogesh Kumar, where to cut the IVC in M mode to look for IVC indices? Good question again. Small things, but they are important.
Yeah, so in M mode, as I mentioned, as I showed in that image, so I'll just yeah, you can identify the hepatic vein confluence. You can identify the hepatic vein for confluence. Just about 0.5 centimeter proximal to that, you can put a M mode and then cut you can for diameter. So this is where you will put the M mode. The confluence of the hepatic vein and the IVC, just about 0.5 centimeter proximal to that, you will put the M mode.
0.5 centimeter.
Just there.
Just
there, just proximal.
5 millimeter from the RA IVC junction, or ideal is just after the hepatic vein. So you are sure that it is IVC. Okay, nice.
Yeah, I think we are running out of time. There's one question on this, maybe the last one. Explain about ECG and Simpson's measurements. 1 or 2 sentence answer, please.
What is
ECG?
the question? I didn't get it.
This is about ECG and Simpson's biplane measurements. Maybe I can take that. The ECG
ECG.
must be included in all echocardiographic evaluations. Please ensure that ECG is connected, because you have to time the systole and diastole based on the ECG tracings. In biplane measurements, for Simpson's method of calculating EF, you have to know the end systole and end diastole. There, the ECG is very handy. It must be used. The systole extends from the top of the
Shiva
R
Kumar, you
wave.
can show your slide quickly because he is explaining in a very good way, so they will understand it better.
So the systole extends from the top of the R wave to the end of T wave. Please note that systole extends from the top of the R wave to the end, middle or end of the T wave. That end systole must be somewhere close to the um, uh, end of the systole on the ECG, that is somewhere proximal or mid T wave. And then the diastole is from that point to the top of the R wave. So just after the P wave, if you look for the frame, that will indicate the end diastole. So if you can do that, only then you will get the correct end systolic and end diastolic measurements of the volumes from which you get the ejection fraction. I think that will suffice for today. If there are any additional comments, please feel free to make Dr. Sanjivini and any of the faculties present, and then we'll close the session.
Sir, should I start with the video?
1 minute, let's have a comment from Sanjivini and
Okay.
any others who want
It
to.
was a beautiful presentation. Your videos were wonderful, and please keep guiding us. From the he is critical care DM person, so certainly he'll help us in our research, which would be conducted later on. Thank you, Shiv Kumar.
Thank you. Thank you.
Thank you, Muralidhar, for this beautiful.
Thank you. Thank you. Anybody wants to say anything quickly? If there are no comments, I would like to thank Shiva Kumar and Dr. Sanjeevani for taking us through this topic. And we look forward to having you once again. The next Sunday being Republic Day, 26th January, it will be considered as holiday and there will be no session on 26th. Please note this. And we are meeting on the 2nd, I think, 2nd, it will be 2nd February, if I'm right. So please come prepared for the talk, and then read a little bit and come prepared so that you can understand what is being said in the talk. With that, I request Shreyasi to play the concluding videos.
Sure, sir.
All aspects of cardiology, cardiac surgery, cardiac procedure, cardiac we'll be adding one more talk in Sunday breakfast session from all these areas, and please join us. Can we go to the next slide, next video?
Yes, sir, sure. I'm playing the next video.
This is the announcement about the IACTA TTE program in Bangalore. Please join us. To be mandatory to all people who are going to participate. thank you so much, and thank you everybody for participating. Thank you, Shreyasi, for being with us to make this a comfortable experience. Thank you so much.
Thank you, sir. Thank you
See
so
you
much.
next Sunday.
Sure. Thank you so much, sir, for giving us the opportunity to host the session.